Okay, so as Dr. Baxter said, this is meant to be a primer just to get us going in ophthalmology. It's called Ophthalmology 101. And hang on, there we go. So it's going to be basics, but hopefully things that are somewhat relevant to you in your future careers as family physicians. The goal is to kind of take a step back and understand a little bit about the pathophysiology and treatment of some of the more common things that you might come across in your patient population. And then we're going to talk a little bit about something that's kind of near and dear to me at the very end. So you guys all recognize this. This is a schematic of the eye. And I think the important thing is that everything, it's like the transduction of photons of light to chemical to electrical impulses that are then interpreted by the brain. It's just links in a chain. If there's a breakdown in any of those links, then that'll affect how you see or how you perceive the world. So for example, light comes in, the first interface that it comes in contact with is actually the tear film. The tear film does a lot of refracting or bending of the light. And, we always talk about, artificial tears. It's this panacea that we throw at everybody, makes them feel better. But actually a dry ocular surface can really blur the vision. It can be really debilitating, and patients often struggle with it. Then the next phase is that the light hits the cornea. So any scarring, cloudiness, deformities, keratoconus, other conditions that can affect how the light is bent will affect your vision. The light then passes through the pupillary aperture and hits the lens. And obviously that's where cataracts will affect how light is perceived or transmitted rather. And common things being common, that's something that you're definitely going to come across and something that we'll chat about. The lights then focus to the back of the eye in the retina, and then the retina converts those signals to electrical impulses. They go back through the optic nerve to the brain. And of course, we have our extraocular muscles that are turning our eyes in different directions. It's always nice to see what normal looks like before we show you some abnormal pictures. In circle number 1, that's the fovea. That's where the photoreceptors are primarily cones. They're really tightly packed together, really small receptive fields. That's what gives you your high definition television viewing for looking at faces, reading, those kinds of things. Then we look in the periphery. We've got the peripheral retina. And you can see how it takes up the bulk of the retina in the eye, that's where the type of receptors are a little bit different. They're primarily rods, more useful for for seeing in the dark, for perception of your peripheral visual field. So things like orientation and mobility are primarily derived from your peripheral retina, and then obviously the optic nerve. And so we can actually, as the light comes in, we can take a cross section of the retina through technology called ocular coherence tomography. And you can see this is what I show the patients, and I explain that your retina is like a layered cake, and every single layer represents a different cell type, and each cell type has a specific job, and the same principles are true. If there's a breakdown in any of those cell types, and then there's then the signals can't come through, a broken link in the chain. So if we flip it on its side, it's the same image, but this schematic kind of blows up those different cell types in the retina. And if you look at different common diseases, you can see how it holds true. So macular degeneration affects this cell layer type called the retinal pigment epithelium. It's the supportive layer of cells for the photoreceptors. And if that becomes damaged, then the photoreceptors become attenuated. Retinitis pigmentosa is a disease of the photoreceptors, so it's going to affect that layer. And then you have something like diabetic retinopathy that affects multiple different layers in different ways in different people, and again will affect how we see. And then as you move further back, you've got your optic nerve. So a lot of diseases can affect the nerves, the optic chiasm, and then as we move further back through the optic tracts and radiations, you get back to the visual cortex, and then where the signals are then processed for higher order processing. And so any breakdown along those pathways will affect your vision in certain ways. So that's all we're going to do in terms of basic physiology. Now we're going to get to some of the more common things that you're going to see. And I tried to consider questions that you might be asked by your patients when it comes to these conditions. So the first thing that we're going to talk about are cataracts. The way I explain to my patients, very simply, everybody's got a lens in the eye, and as the lens becomes cloudy over time, it's like looking out of a dirty window, and the only way to fix it is to physically take that dirty window out and replace it with a new clean lens that sits in their eye for the rest of their life. Many different causes for cataracts. Aging is obviously the most common one, but everything from inflammation, medication such as steroids, for example, metabolic disorders, various other ocular conditions, traumas, congenital disorders, all can cause cataracts. The important thing to know is that cataracts can affect your vision in many different ways. Everything, so obviously,
your attention, please. This is a test of the overhead paging
obviously
system
decreased
only.
visual acuity.
Your attention, please.
But people
This is
talk
a
about
test of the
glare,
overhead paging
halos
system
around
only.
lights,
Your
diplopia,
attention, please. This
color
is a test of
desaturation,
the
all of
overhead
those
paging
things.
system only.
There we go. So it can affect you in many different ways. So if you're a little bit squeamish, this might be time to turn away. I thought I would show a quick video of what cataract surgery is all about. The reason I bring it up is that patients also often come in and say, well, it's done by laser, right? And in fact, for the most part, it's done manually. And then patients also ask, well, do you take my eye out? And we're like, no, the eye stays in the socket. And so we start to describe how it's done. And so I figured I would show you guys, and then you can get a sense of how it's actually done and maybe describe it in very general terms to your patients. So we're going to start now. So when we start this cataracts, let's mute that. So when we start the surgery, we have to get inside the eye. So we make 2 small incisions. The first one is a side port there. Then we next fill the eye up with a clear jelly, and we do that to create space in the eye. It's like a balloon, and we want to make sure it maintains its form while we're doing the surgery. But that jelly also protects different structures within the eye. Next, we have to create our main wound. So this one's going to be a little bit bigger, and this is where the majority of our instruments are going to come through. Now, the lens inside the eye sits inside a bag. And in order to access that lens, we have to make a tear in the bag because we want to keep that bag intact because that's going to be the natural scaffolding that we're going to use to house the lens. And so the way we do this is by creating a very controlled curvilinear tear that's very stable and then that won't run out or tear on us. And that it's kind of like running a tear in a bag of potato chips. And so once we complete that, now we have access to the lens, but the lens is still stuck to the bag and we need to loosen it up. We need to mobilize it. And so the next thing you're going to see is they're going to come in with a cannula and they're going to inject fluid. And that fluid wave then will wrap around the lens and cleave the interface between the bag and the lens. So now you can almost spin it around, you can move it. You can't take it out yet because it's too big. The hole that we created was not big enough to remove the lens. So the next step is to then break up the lens in a controlled fashion. And there's many different ways to do that. We often use an ultrasound probe, which is what they have there. And that big instrument basically can grab the lens pieces, it can hold onto it, it emulsifies it. It's like a jackhammer that breaks up the pieces. And so you're going to see here, they're going to grab it, crack it in half and make it into smaller, more digestible pieces. So there's that kind of big crack. And so they're in a piecemeal fashion, they're going to keep going around, breaking it into smaller and smaller pieces. And eventually it's going to come out and you're going to be left with kind of this thin layer of cells that are still stuck to the bag. And we need to clean all of that up just to make sure that there's no inflammation and scarring after the surgery. And so he's going to come in with a different instrument. It's almost like a small little vacuum cleaner. And he's going to basically peel those residual layer of cells off. It's called the cortex. And it's almost like peeling a banana strip by strip. And eventually you're going to have a fairly clean bag that you can polish off. And then you're going to inject a lens inside in the bag. And the lens comes in scrolled up. And as you insert it into the eye, it unfurls like kind of like a flag and then sits nicely centered. Going to jump a little bit forward. So that's the lens coming in, and then it kind of slowly splays out. And if it's all gone well, that takes about 15 minutes or so. And at the very end, he's now just removing some of the jelly inside the eye. So that's cataract. That's how cataract surgery is generally done manually. Now, you've definitely heard of laser-assisted cataract surgery, or patients have, and so it's important to note that the laser-assisted cataract surgery, it basically what it does is it does some of those steps that you do in traditional cataract surgery, but it uses a laser for it. You still have to do the bulk of the surgery manually, but there are parts of it that can be helped with laser. Laser-assisted cataract surgery has been shown to be non-inferior in terms of efficacy, in terms of safety, but the cost effectiveness is certainly up for debate. I imagine in the future, with economies of scale, it'll become more accepted. There are also some limitations as to when you can use it, but I wanted to just give you a very quick kind of summary of what they do. So the first thing that they do here is they use a device to dock the eye. It's with suction, and that'll stabilize the eye so it doesn't move on them. And we're going to see it right here. You're going to see kind of a fluid wave as it comes in contact with the eye. 3, 2, 1. It's going to come across right around there. And so once the eye is secured in place, they're going to take measurements of the cornea, the topography of the cornea, of the lens. And then you can see here, this square, that's the main wound. This rectangle here, that's the side wound. This circle over here, that's that curvilinear tear. Those are, so now they're creating the operative zones. They're creating the dimensions and the placement for them. And once they're in place, they're going to take some measurements of the lens, and they're going to quantify the depth of the lens, because you don't want to break the back of the bag. And so they're going to kind of get a sense of the limitations of where the laser should be. And then I'm going to fast forward to right around here. They're going to start the laser. And so you're going to see a circle being formed. That's the laser at work. Those are some bubbles that are being formed as the laser is working. And it's also creating, it's also chopping up the lens at the same time. You're also going to see the main wound being created here in just a second. Just going to wait for it. So here's that main wound being performed. They're going to do, and then they're going to do the paracentesis, or that side wound over here. And so that's kind of it. And then the rest of the surgery moves forward as more or less as described in the previous slide. So what are the implications of all that? Well, when we're talking to patients about cataract surgery, there's a few different decisions they have to make. First of all, we have to measure the eye to understand what type of lens we're putting in, how long is the eye, what's the curvature of the cornea, and there's different machines that allow us to do that. There's a simple ultrasound. This is optical biometry, and then topography for more of the high-end lenses. Then the patient has to decide on a lens type, and some are more basic, some are more advanced, some are not indicated for every patient. And then they have to decide on the surgical technique, which we went over, the manual and laser assisted. And I think the important thing for me is that there's always a free option, and patients should never feel pressured to have to pay for surgery when everything at the very least will be covered. So in terms of wait times, and I got this data from Health Quality Ontario just last week. So this is including COVID. T1, which is the first box, relates to the time of the referral that we might receive from you as a family physician. So the time that we receive the referral to the time we actually see the patient in clinic. The target's 182 days, the Ontario target, and we're well behind the average, but still below the target at 139 days. That's at the physicians at KHSC. Time 2 is the time from the time the patient was seen in clinic to the time that they're actually going to have their surgery, and that's another 222 days. So from the time that you send a patient to us to the time they actually get the surgery done is on average a year during these COVID times. And that kind of makes sense because if you look back, if I look at my presentation from a year ago, the wait time was about kind of 8 to 9 months. And that extra 3 months is basically kind of when the length of time things were shut down during COVID. And so this is what you can see here. This is the percentage of patients whose surgery was completed within the provincial target wait times. And most of our patients were, 80% were. COVID hit, and now we're down to about 20%. So how are we going to make that up? I have no idea. We were already operating at, I would say, almost more than 100% capacity. And so even if we got to that level, we're still going to be behind the 8 ball. Other considerations, we often need a medical history and a list of medications. We used to ask our colleagues in family medicine to help with the preoperative history and physical, but we've done away with that to optimize resource allocation. Surgery is often done topically, is for the most part done under topical anesthetic. Patients are offered sedation here. In special cases, whether it's developmental delay or other special cases, we can do the surgery under general anesthetic. Okay, so we're going to move on to macular degeneration, another very common condition. So AMD, there's a dry form and a wet form. In the dry form, as I mentioned earlier, you've got this retinal pigment epithelial layer, this layer of cells over here that their job is basically to support the photoreceptors on top of them. But in this dry form, that layer of cells starts to break down and atrophy. And as a result, the overlying photoreceptors start to attenuate. And as you can tell by the name of the disease, macular degeneration, it primarily or predominantly affects the macula. And as a result, you start to lose that central vision. The peripheral vision is still preserved, but it's that central vision. So one of the key things to let patients know is that this is not a disease where you will go blind. That's not how this disease operates. You will always have that peripheral vision preserved, but it's that central vision that certainly can be lost. As you probably know, there's a wet form of this disease. And in the wet form, you've got these new blood vessels that grow up through underneath the retinal pigment epithelium and into the inner retina. And those blood vessels are not normal. They shouldn't be there. They can leak, they can break, they can bleed, they can scar, and none of that is compatible with good visual acuity. And again, as a result, you start to lose vision centrally. So how do we manage this? For dry macular degeneration, a lot of it is risk factor modification. So, stop smoking, optimize your cholesterol, blood pressure, UV protection. There's been large randomized controlled trials that have showed that a specific combination of minerals and multivitamins can reduce the risk of progression. It's progression from a moderate state of disease to a more advanced state. And so there's really no good evidence to, number one, show that taking these vitamins will prevent the onset of macular degeneration. Patients often ask about, well, what about carotenoids like lutein and zeaxanthin, and a subsequent large randomized controlled trial show that actually there were no benefit. One thing to know is that if you have a patient who is a smoker, there is a formulation that does not have beta carotene, and because beta carotene was shown to increase the risk of developing lung cancer in smokers. In terms of wet macular degeneration, we definitely have more tools in our tool belt to manage that. We use injections of anti-vascular endothelial growth factor. Those injections cause the blood vessels to involute, to shrink away, and as a result, a lot of that swelling and hemorrhaging in the eye resolves. Patients are treated in terms of when they have active disease, they're treated, and the frequency depends on their response to treatment. It's been a huge, the advent of anti-VEGF has really changed the paradigm of how we manage this disease. It used to be that we use laser to ablate those leaky blood vessels, and that helped to arrest the disease disease, but it caused a lot of iatrogenic collateral damage. Now with anti-VEGF, not only will 90% not progress further, but 30% will actually improve some of the vision that they've already lost, which is amazing. In terms of risks, the big one is that we're always worried about is endophthalmitis, because that's vision threatening for sure. Retinal detachments we also talk about, and there is a systemic risk of a thromboembolic event as well. In terms of diabetes, here's another little, there we go. Fundamentally, diabetes is due to, or diabetic retinopathy is due to a loss of parasites in the blood, in the arteries, thickening of the basement membrane, and a breakdown of the blood retinal barrier. And as a result of all that, you get these small hemorrhages in the retina. You develop these microaneurysms. You have swelling, exudates, and all that is obviously not compatible with good visual acuity. You can also develop new blood vessels, so neovascularization, and this is just, and it's treated much the same way as wet macular degeneration, where we use anti-VEGF injections to cause some of those new blood vessels to involute and shrink away. Let's skip forward here. This is a picture of the back of the eye. And when we're examining patients, we lump them into two very general categories. There's non-proliferative and proliferative diabetic retinopathy. And so for proliferative diabetic retinopathy, you get neovascular fronds, so new blood vessels growing. And as I previously mentioned, those blood vessels, they're not normal. They shouldn't be there. And they can break, they can bleed, they can scar, they can cause retinal detachments, all sorts of things. This is an OCT of the macula, and as you know, I showed you that layered cake before. You can see here there's this hypolucent kind of area that relates to some swelling at the back of the eye, again due to those leaky blood vessels. And what we can do is actually inject a dye and then take photos as the dye circulates in the eye. So intravenous fluorescein angiogram, and you can see all those hot spots here are areas where there's new blood vessel growth, and we can see the leakage that's forming. Those little little white spots are microaneurysms that are highlighting as well. So from your standpoint, what do you do to, or how do you initiate screening? What's the timeline? For type 1 diabetics, you can initiate a referral for a screen 5 years after diagnosis and greater than 15 years of age. For type 2 diabetics, it's at the time of diagnosis. If we see them and there's no retinopathy, we'll probably either see them if they're type 1 diabetic every year. If they're type 2 diabetic, maybe every couple of years, depends honestly on resources and availability. And then if there is retinopathy present, it's really at the discretion of the ophthalmologist and the degree of retinopathy, but it'll be certainly less than a year. In terms of treatment options, obviously this is an ocular manifestation of a larger systemic condition, and the mainstay is to optimize their blood glucose levels, but also cholesterol, blood pressure, screening for other diabetic complications. We talked about anti-VEGF and steroid treatment. Laser and surgery are also options. And so if we go back to our picture over here, you can see that there are these pock marks in the periphery, these small retinal scars, and those are areas where laser was introduced. And the idea being, you've got you've got retina that is not getting enough oxygen, not getting enough nutrients. It's screaming out and releasing VEGF. We need more. We need greater blood supply, and so new blood vessels grow. And so if we ablate that tissue, we can eliminate that signal and minimize the risk of new blood vessel growth. The downside is that we actually can, as we're destroying or ablating that peripheral tissue, we're damaging it, and you're starting to lose that peripheral vision. And that can have some significant implications on your functional ability, on your ability to meet the legal requirements to drive, which impacts independence, safety. And so there's definitely a bit of a rabbit hole. How aggressively do you treat something, understanding that you're also you can potentially cause more damage than harm. Glaucoma, I think this is the last one that we're going to touch on. So the way I describe it to patients, glaucoma is the eye's like a sink. There's a tap that's on and a drain that's flowing the fluid out. And there's the balance between inflow and outflow will dictate what the pressure is in the eye. And we know that if the pressure in the eye is too high for too long, it'll slowly damage the nerve at the back of the eye. And this is critical because the nerve is that bridge that connects the eye to the brain. And if those signals can't walk across the bridge and get to the back of the brain, the visual cortex, then you start to lose vision. This is a picture that I showed you earlier of a traditional nerve. Just to give you an example, or just to kind of clarify, that central clearing in the middle, that paler area, that's an area that's devoid of tissue, and the neuroretinal rim is this kind of, it's like a donut, and the pinkish area is that neuroretinal rim. In a glaucoma patient, you can see they've lost a lot of nerve tissue, such that the center is hollowed out, and that neuroretinal rim is much thinner. And so that's what we talk about cup to disc ratios. What is the ratio of this area that's no longer present to the overall nerve? So here it's kind of 0.3 or a third. Here it's closer to 0.7, 0.75, 0.8. There's many different types of visual field defects, but I would kind of direct your attention to this last one here. Unlike macular degeneration, glaucoma is definitely a disease where you can go blind. It's a silent disease. So you talk about pressures and patients think, oh, I can, sometimes I feel pressure in my eye. I'm like, no. These are the types of pressure changes that we're talking about are not anything that you would feel. And often we come across diagnoses just, these are incidental findings on routine exams. And so it's really important to catch it, because once you lose nerve tissue, you can't get it back. So this is my really poor man's version of what they may perceive, although, again, you don't know what you can't see. And so this is not really how they perceive the world. In terms of treatment, everything we do is designed to either turn off the taps or open up the drain. And so we have a variety of different types of or classes of medications or drops that attack both of those mechanisms. We also have a laser that affects the outflow, and surgery, we can actually create secondary drains in the eye to reduce the pressure. So those are the big diagnoses. I have a couple more just small hodgepodge loose topics. Patients often now ask about cannabis, medical use of marijuana for glaucoma, and the COS, the Canadian Ophthalmology Society, came out with a position statement and basically states that it does not support the use of cannabis because it's short-acting, it has side effects, psychotropic and systemic side effects, and there's absence of evidence of its long-term benefit on how it and it doesn't necessarily alter the course of the disease. In addition to that, we have many more less harmful, more effective modalities to treat glaucoma. So certainly not suggested. Driving also often comes up. There's many different requirements depending on the license. In general, visual acuity 20 or 50 or better with both eyes open. There's also some visual field requirements, but I often tell patients there's a lot more to driving than simply visual acuity. It requires a complex integration of cognitive and psychomotor skills, and even in terms of vision, we measure visual acuity, we measure visual field, but there's also glare, contrast sensitivity, speed of visual processing. All of those things are integrated together. And so while patients often say, I feel safe, I just go to the corner store and I only go in, during the daytime. In terms of the Ministry of Transportation, it's black and white. They don't care. and you either meet the requirements or you don't. And physicians don't actually make that determination. We simply send the results to the Ministry of Transportation, and they're the ones who will ultimately make the call. And so this is an example of a visual field, and if there's any absent or black boxes within that visual field, then they wouldn't pass. And that's kind of how I explain it to patients. So that's the kind of the ophthalmology primer. I'm just going to show you maybe 2 or 3 more slides on vision rehabilitation. So any of these diseases, if you take it to the nth degree, they can lose vision and lose vision permanently. And so any vision that can't be improved with standard glasses, medicine, or surgery and affects your ability to function is termed low vision. I like to show this picture because these are the type of patients that I often deal with. I have the full spectrum, young to old, but predominantly elderly patients are who I see in my clinic. And vision loss is becoming a growing public health concern, namely because vision loss typically goes hand in hand with age. And we know that our population is getting older. The population over the age of 65 is supposed to double over the next 25 years. And so this is kind of a growing epidemic. I think it's potentiated by the fact that vision loss affects the more vulnerable elements or people in our population. So if you are if you're a current smoker, if you have other comorbidities, if you're a diabetic, all these things you're going to have. If you have reduced cognitive state, you're more likely to have low vision, and as a result, your risk profile elevates in terms of risk of falls, risk of mental health, anxiety, depression, admission to long-term care facilities. All of these things goes up, and there's a cost to the patient and a cost to society. And so the question is, well, how do we mitigate that risk and how do we mitigate that cost? There's good evidence that vision rehabilitation helps. In there's a lot of gaps in care in terms of vision rehabilitation. In the Southeast Lynn, we've created the Southeast Ontario Vision Rehabilitation Service, so that if you are a family physician, an occupational therapist, an ophthalmologist, optometrist, whoever, you can access this service. There's a standard referral sheet. There's a call center now. We triage everybody over the phone. We do intakes, and we're developing clinics across the region so that we can eliminate that barrier of transportation and improve access to care. So that's something that I'm happy to talk about at some other point, but I think that brings us to the end of my presentation.